I'd like to dedicate this session to Professor Chesmal. Chesmal was a psychiatric epidemiologist. His focus was on mental health within conflict-affected communities, but also mental health of labour migrants and families. I'm going to present some of the empirical data in this presentation too, and this session I dedicate in his honour. First of all, I'd like to thank Anne for inviting me and the team that, as Anne mentioned this morning, I've smuggled into my presentation as well through irregular means. Professor Ingleby, a guru with regards to the migration health data, and Rachel Burns, a rising star in global health. I've got to say that I'm going to slightly sort of be a little bit more contrarian. I work for IOM, but I think some parts of this is quite self-critical because I think we haven't really invested in health informatics, in migration health informatics. And I think we are still a long way in terms of investing in this arena. So the SDGs talk about leave no one behind. I really think migration health has been somewhat left behind in the global debates around migration and development, and even the compacts doesn't have a dedicated theme as such, and it's sort of, you know, the health folk have been relegated to the sidelines rather than the mainstream agendas. And this is why I think it's really important that, Anne, for your invitation to really provide a space within this ecosystem of researchers, government officials, UN partners, to talk about the importance of migration health. Look, I'm going to speak for 30 minutes, so it's going to be quite a quick run through, and so I suppose just sit there and marinate your brains with some of these concepts of migration and health. But we're going to go straight into some case studies, some practical stuff, which David and Rachel will be presenting. I'd like to start off with this quote by our outgoing Director General, William Lacey Swing. And he made this statement at the second global consultation in migration health in Sri Lanka in February of last year. And he said, "We need to be guided on the basis of firm evidence and not superficial and misleading perceptions. We need to be guided by science and pragmatism, not fear and misinformation." And it's because of this polarizing, toxic debate around migration, more than ever, we need to be quite tethered to evidence. But also, as Anne mentioned, and as Bella mentioned as well, it's about communicating that data as well. Now, a little bit about myself. As Anne mentioned, I'm the head of migration health research and epidemiology at IOM, and my day job actually involves looking at health data from our three programs. We have a health assessment program, a technical cooperation program for member states, as well as migration in health in crisis program. So the unit really looks at improving evidence generation across these three pillars, and some of the kind of work that we do on a daily basis. IOM does around 400,000 medical examinations of migrants and refugees, and here is a sort of a quick snapshot of the tuberculosis data that we have found through different migrant and refugee groups. So this is just a quick sort of glimpse into the kind of work that we do. And here's data on nutritional status of Syrian refugee children that we've assessed in various countries in the aftermath of the displacement. So as I mentioned, I'll be speaking for 30 minutes, covering the key concepts of migration health, touch on some global frameworks, sources of migration health data, gaps and trends, and then we're going to go into the case studies. And I think one of the things that I really like to emphasize is being acutely aware that a lot of the work around migration health And it takes place in the global north. It's a lot of research activities are done in Europe and North America and Australia, but not enough is being done in the developing nations. And I think one of the key messages of this presentation is how we can build capacities with scholars, with partners in low to middle income countries, for example, in order to facilitate the data that we need for policy and practice. So my case study will focus on a developing country example, and that of Sri Lanka. And then we're going to go into an example of a regional approach through the MIPEX index, Migration Index Policy Index, the health strand, and David's going to talk about that. And then we're going to look at the longitudinal study that Rachel and her colleagues in UCL in Public Health England are embarking on. So, some quick definitions. What is health? Health is not an absence of disease. It is a state of physical, mental, social, spiritual well-being. This is the WHO definition, and it's a definition that has been enshrined within the 1948 Constitution of WHO. So then what is migration and health? Now, these definitions are not set in concrete. These are definitions that are evolving. It's an active document. We've had a lot of debates around this, even at the first global consultation, the second global consultation. But in general terms, migration and health has two dimensions. It's not just the health status of a person, the morbidities and mortalities. It's also about the interplay between human mobility and health. And Bella talked about this in his presentation about mobility. So migration health also involves the second component of how disease spread through human movements. And we can see that through tuberculosis, leptospirosis, Ebola, etc. And I'm going to touch a little bit on that later in my presentation. So if that's migration and health, what does migration and health data entail? And data in the migration health sphere is generally defined as characterizing health status, but also the social determinants of health. And this is a really important concept that we'll unpack a little bit later on through a schematic. But what this says is that, you know, it does require a multi-sectoral approach to addressing migration health. It's not just the domain of the Ministry of Health, it's the domain of a multi-sectoral effort to address those determinants of health. So it's quite an expansive definitions, and these are evolving, right? If you look at some of the key milestones or within the international frameworks on migration health, the 2008 World Health Assembly Resolution on the Health of Migrants was the first real action to emerge, where at the WHO there was a call for member states to promote the equitable access to healthcare for migrants, promote multilateral cooperation to address the health of migrants. Now that was 2008. Following the resolution, there was a global consultation in Spain, which was organized by the government of Spain, IOM and WHO, and that really set a framework, which I'm going to present in the next slide. And the framework is a compass, essentially, for member states to utilize and calibrate action around migration and health. From 2010 to 2017, we had the second global consultation in migrant health, and this was done in Sri Lanka under the auspices of the government of Sri Lanka and the president of Sri Lanka. And that was really a stock take about where are we, what has happened in the last 7 years, and what action has happened. And sadly, not much is the quick answer, but it was a real meeting where member states, the international community, civil society groups, and researchers actually had a Colombo statement or a declaration to reaffirm commitments to advancing migration health. So where's data in this framework? It is central. Monitoring migrant health, identifying key indicators, ensuring standardization, comparability of data on migrant health is a pillar in the four-pillar framework of the resolution. And this is where, and this is what I'm sharing at this meeting, that it is a part and parcel of the framework for member state action. So when you think about migration health, and you can see I'm rushing a bit because I have to meet the 30-minute deadline, what are some of the key policy questions on migration health? So here are some of the questions that emerged from the first consultation. What are the health outcomes of migrants in comparison with the host population? Are migrant variables integrated within health information systems, health surveillance systems, and DHS surveys? Are migrants included in health policies and disease strategies? Do migrants have the right to health care? Is this enshrined in domestic law? And multiple questions. So let me give you a practical example of an analytical piece trying to assess this for 27 member states, 27 countries in Asia Pacific. So this was a paper that we just published in May of this year, and this study looked at whether migrants were included in national pandemic influenza preparedness plans. So every member state, there's a convention body called International IHR, the International Health Regulation. It's a binding treaty body that protects communities, societies, nation states in terms of the global spread of an outbreak, like Ebola, for example, or pandemic influenza. And when we looked at the national action plans, we found only 3 countries within the Asia-Pacific region that had actually included the non-citizen within their plan, their action plan. So imagine a public health emergency event, and so a large component of the migrant population are excluded. So this is an example of a response to one of those questions. This was touched upon briefly this morning as well about domestic maid abuse. And one of the real sad things I want to share, and I see a lot of young researchers here, is to really look at data on these phenomena that are in mainstream media, but when you actually look at the data and the scientific literature, there's very little studies on. So this is a study that we did on the patterns of domestic abuse amongst female labor migrants coming back from the GCC, the Gulf Cooperation countries. And what we found in this study was a scarcity of information and data. And these are some of the, so this was a study that we did with the forensic pathologist in Sri Lanka, and we did it over a 6-month period. And so any medical legal case that was reported to the judicial medical officer that was involving a migrant, we included in the study, and with informed consent did analysis. And what we found that violence against migrant workers, and again, this is not a time to sort of unpack this study, but this violence in physical, sexual, psychological, verbal, financial abuse and neglect. So all forms of violence were reported by the cohort that we looked at, but there was also patterns of this behavior. And I'll stop there because this can go on in a different trajectory. But what we found by doing this research is that there is certain data that can inform interventions, pre-departure training programs in labor migration, with the Labor Migration Ministry, for example, and this is an example of that. I mentioned earlier that migration and health, there is a social determinants effect. So it is a multifactorial effect from individual factors, lifestyle factors, living conditions, working conditions. It's not that migration makes people vulnerable. It's there are things within the whole cycle, from employment, the living conditions, lifestyle factors, genetic factors, that actually predisposes people to health risks, but also resiliencies. So I think this message that it's not, debates on migration health has often been driven by this concept, and we have many political leaders, without mentioning names, that talk about migrants as vectors of disease, and with exotic pathogens coming through borders. And of course, I mean, there are trajectories where when certain forced migrant groups are fleeing, for example, a conflict zone where there's been disruptions in health services and health systems, of course, immunization programs are disrupted and one is more susceptible to vaccine-preventable disease. Of course, there is some there, but not the sort of rhetoric that we hear being talked about by certain political entities. But in reality, this relationship between migration health and its interplay, it is a complex one. And I think I sometimes find that even within, again, being self-critical and as being a sort of an outlier and a polemicist, I think even the UN, we get into this drumbeat around the vulnerability angle. Migrants are vulnerable. Of course, there's vulnerability, but there's also trajectories of resilience and empowerment through the migrant journey. I'm sure many of you have heard of the healthy migrant effect. The fact that those very same labour migrants that I was showing photos of actually undertake a pre-departure medical assessment. So it's screening for diseases before going abroad. Now, let me not unpack issues around the Gulf countries' approaches to deportation of migrants based on HIV status, for example. But what I'm saying is that there is a relatively healthy migrant effect that takes place, which also can, by the way, in longitudinal studies, can go back into vulnerabilities. But what I'm trying to say is that there is unpacking this relationship between migration and health is an important endeavor, and what we need, therefore, is better evidence. And not just clinical data, but we need to understand the determinants of health, the housing issues, the legal frameworks enabling and disabling. How portable is health insurance? And even if it's present, does that package provide access to primary health care, for example, if the person is a sufferer of chronic disease? So the reality is, and this is the sort of earlier statement I made, is that migration health has been somewhat neglected by policymakers, researchers. And I think, and I'll show you some empirical data to prove that statement as well, and even the compacts. And so we all have a role. You have a role as a researcher, as a policymaker, a civil society activist, in order to address this. Okay. I think I might skip this, but it's basically saying that there's risks and positive enabling trajectories at each phase of the migration cycle, in the pre-migration phase, during the movement, on arrival and return. So there are well-being of migrants can go through positive trajectories and vulnerabilities and go between those domains. And so just to give you a simple snapshot of this, actually not simple, this was some research that we did, again with Professor Chesmal in Sri Lanka many years ago. This was done in 2015. And this was, we looked at labor migrants from Sri Lanka that were going to the Gulf states, and we looked at the children left behind. And we looked at mental health and nutritional effects of these children that were left behind. But we also looked at their caregiver, which was usually an adult, elderly member of the family. And what we found was that in the Sri Lankan study, that yes, there was child psychopathology at quite a significant level. 2 in every 5 left behind children were shown to have mental disorders, suggestive of social-emotional maladjustment and behavioural issues. Nutritionally, they weren't. There was no significant difference. But when we did this research in Philippines, there was very little psychopathology in the Filipino left-behind children. And actually, there was a positive effect on nutrition. So, and we were doing these studies with, a population sample where we compared a migrant household and a non-migrant household, and a child from a left-behind migrant household and a non-migrant household. So, this was a comparative study. And we found that, and we're actually doing research now in Cambodia as well on the children left behind there, which, by the way, in Cambodia, 94% of their labor migration is irregular. There is no, it's not a regularized flow, 94%. It's a very different kettle of fish to Sri Lanka, to Philippines, and to Bangladesh. So what I'm trying to talk to you about is that diversity, about being nuanced, about trying to find what are those health outcomes and health risks. This was a piece that Chesmal and I did in The Lancet, talking about the mental health of the low-skilled migrants and the families left behind is a neglected research agenda. So despite this rhetoric for migration for development, the social and health consequences haven't really been explored. And the assumption we make that remittance automatically trickles down to purchasing better, say, protein through chicken, through the food basket, doesn't necessarily pan out unless you kind of do these studies. Sorry, I'm not going to get into this, but this was a comparison of Thailand, Moldova, Sri Lanka, Vietnam, Indonesia, on the children left behind, and showing the kind of different impacts of migration. What was really important, and this was raised earlier, when you do these national surveys, and this was at the back of a migration health agenda in Sri Lanka, we found these facts that just we never anticipated. That common mental disorders amongst the adult left-behind members of the families were 3 times greater than the comparative non-migrant adult. So the mantra that we started to chant was, who cares for the caregivers? So that we worry about the migrant, we worry about the children left behind, but actually it's the caregivers that were taking the burden of care. So Sri Lanka has something like 2.1 million migrant workers. It's about 26% of its labor force. 10% of its population, and these are registered. We don't know about the other irregular. Can you imagine the burden of care is being taken by the elderly caregivers, and so, but there was very little service coverage, respite provided for them. How much time do I have?
If you want to smuggle people in, you need to finish up soon. So
oh my goodness. Okay, I'm going to have to smuggle David in pretty soon. Look, broadly speaking, the types of data in migration health include health status, so the mortality, the morbidities, the disabilities, nutritional status, health services coverage, access, availability, affordability, and the social determinants of health. So these are the 3 broader categories. Now, there are routine data sources, and we've been through some of these in previous presentations. So there are the household surveys, there's the vertical disease control programs like AIDS, TB, and malaria, for example. And you'll be quite interested that WHO and IOM are actually redefining a new definition of migrant malaria, or cross-border malaria, and it's still debated, but it's become such a key issue in malaria elimination. But these are data sources that I think we have the opportunity to capture migrant data, and then there's, of course, the non-traditional data sources. This is part of a fact sheet that we've done with IOM, GMDAC has done. And I was going to go through the kind of data sources like the DHS surveys, the health institution-based records, but we don't have time for that. and I wanted to sort of end off with what are some of the immediate buys or the low-hanging fruits that we can do to quickly capture migrant health data, and how do we build national capacities, scholarships, ethics, and innovations around this. But I think you'll hear that with the case studies that will be presented now. I'll just say that this is some work that we've just published in the BMC Public Health, and we basically looked at the last 16 years of migration health research. This was around 28,000 publications and documents, and this is the heat map of who's doing what where in terms of migration health data. And you know, when you see this map, it's clear that much of the data and research is being done within countries, America, Europe, Australia, large volumes of migration is untouched in terms of finding the health outcomes, especially Bella mentioned about the Asian region as one of the highest volumes of migration, yet some of the lowest outputs within the health domain. So a lot of work to be done. There is, I mean, this is an analysis in itself, but migrant workers, which comprise of the largest chunk of those international migrants, are having only 6.2% of representation, whereas refugees and asylum seekers 25.4%. There's a lot of work to be done, and these are collaborations of who's doing the research. I don't have, unfortunately, the time to go through the Sri Lankan case study, so I will hand it over to David to do the case study on the MyPECs. Thank you so much.
Good afternoon, everybody. I'd like to thank Kol, especially for smuggling me onto the program. I'm going to tell you about the MyPECs health strand, which is an instrument for measuring how migrant-friendly a health system is. It measures the inclusion of migrants in health systems, so it's quite broad. However, it does not measure the health of migrants. It only measures how healthy the policies are, which have an impact on their health. But the first question is, why should we need such a thing? And in particular, why would you want to express policies as a number? Many people think it's crazy. Policies are qualitative things. You can't quantify them. And in any case, we have masses of studies on this topic. But the problem is they all make a different selection of countries. They look at different issues. They use different methods, concepts, criteria. So you can't make a joined-up picture of what they're all saying. We can't make comparisons between countries, or we can't look at changes over time within countries. And we also need to identify the strong and weak aspects of each country's policies. So it's, if you like, it's a benchmarking instrument. That's what everybody's talking about these days. We've got to benchmark. And the way we did it was not to start from scratch, but to take an existing migrant integration policy index called MyPECs and simply tack the topic of health onto it. Now, this is what MyPECs looked like before we came along. They studied labour market, family reunion, education, political participation, long-term residence, nationality, discrimination. Seven, they call them strands. And they did that in more than 30 countries, but most of them European or other OECD countries. And when I say we simply tacked it on, well, it was an enormous task, in fact. It kept a lot of people busy. We had people from the Cost Action Adapt, that's a European network, The IOM in Brussels was subsidizing it. They have a project called EquiHealth, financed by the EU, and then the Migrant Policy Group, which were the developers of the index. And we started in 2012. MPG joined us in 2013, and in all, 155 researchers worked on this thing for about 4 years. So it's a massive, well, I'll try and show you why it was so much work. It was based this time on 34 countries in the EU and European Economic Area, and some neighbour countries, altogether 38. Now, MyPEX itself has been going since 2003, and its repeated measurements...
David, I'm so sorry. Could you use this microphone
Yeah.
instead?
Okay. Yeah, that's better. MyPEX has been going since 2003, and it's like a snowball. It gets bigger every time. Every 4 years they come with a repeat. So it's a longitudinal study. That made a difference because when you design an instrument for a longitudinal study, you have to get it right first time. You can't improve it every time because then you can't compare the results. So it had to be right first time. Now, normally it's a big headache to decide what to put in a measuring instrument. What are the relevant variables or indicators? But again, we chose a ready-made solution. In fact, there are a number of efforts already been made to summarize these. We published an article on these, but we started from the most recent one, and the most elaborate one, which was the Council of Europe recommendations. And these were published in 2011. And these summarized what you have to do in order to make a migrant-friendly health policy. So this was ideal for our purposes. Now, MyPEX has a standard design. For each strand, you have to have 4 dimensions. And this is how we organized the material. The most basic one is entitlement. Are you legally entitled to be included in the health system? If you can't get in, then there's no point in measuring equality, because you just have to look after your own health and healthcare. So we look at entitlement and accessibility. Now, both of those are to do with access, but it's a huge topic aspect, access. We separate the legal and the administrative and the practical aspects of access. Then we look at the responsiveness, or how well the health system is adapted to the needs of migrants. And finally, measures to achieve change. Well, these are things like data collection, whether you have good leadership, governance, an action plan, consultations, things that you need to get the show on the road. And lastly, the point is that we measure equity, fairness. We don't measure the absolute quality of a health system. So the range is enormous in the countries that we studied. The most fancy, elaborate, expensive health services and very primitive ones. But the key question is a migrant on equal terms with national citizens? Then, for constructing the state scales, for the fine detail, MyPEX uses what I call a great shot approach. Instead of trying to find a small number of key indicators, it chooses a lot of indicators. For example, there's got 4 dimensions, and there's in principle 6 questions in each. I mean, even in the questions you have multiple indicators. In the health strand we have 38 indicators. And the philosophy is that we know some of the indicators will be not very useful, but they will cancel each other out. If there are biases, they will tend to cancel out. And the result was very good. It has very high internal consistency, has a very clear structure. And I think that's due to the incredible length of time we spent developing it. We piloted it, like I say, we had to get it right first time. Endless fine-tuning to discover all the ambiguities and the weaknesses of the questions. Most questions, I think, we had at least 4 or 5 versions before we got it right. If you want to look up the results, the best way to do it is just ask Google for MyPEG's health strand. You can also look on the IOM's bookshop or the EXA health site. Yeah?
Okay.
Even better. Now, very quickly, what have we learned so far? Well, basically, the detailed results have been there since the end of 2016, so we're only just beginning to mine the data for interesting findings. But here's a sample. Like I say, the structure was very good. We can look at the total scores. This, by the way, is Australia, Canada, New Zealand, and the United States. This goes from cold to hot. That's to say, cold is blue, and then you have green, yellow, orange, red. You can see that the worst countries for migrant health are these blue ones here, the Baltic states, Poland, and so on. Italy comes out well, UK, Norway, Switzerland. But I should issue a caution about this map, because the total scores are, first of all, the total scores mask a lot of differences. For instance, there's some countries that are very good on quality but bad on access. UK is the best example. France is the opposite. Very good on access, but not at all interested in responsiveness. And the other point is, MyPEX has a rather bizarre method for selecting regions. Some countries are divided up into regions, and often the regions have very different populations of migrants. So you get, for example, in Spain, Catalonia, Andalusia, they have very many migrants, and they also have a highly developed state-of-the-art there in migrant health policy. So Spain is looking good. Spain is orange. Italy is even better, but that's only in the migrant-rich regions. So bear in mind when you see that. It's not necessarily true for the whole country. It is more relevant for migrants, but it's not very objective. Then let's look at the EU 15, that's the traditional, the old EU members, and the EU 13, that's the recent accessions since 2004. You see a very big difference there. The traditional old EU countries are actually much better than these new countries, and especially on responsiveness. In Eastern Europe, you ask if they do migrant-friendly healthcare, and they think you're crazy. What are you talking about? Everybody gets the same healthcare, and that's a tremendous achievement. Why are you asking us to do special things for migrants? So there's a problem there. You can see here, this is the responsiveness scale. Sorry about the colors, they're a bit confusing, but it goes 8 countries score 0. And right over there at the top, we have the UK with 93 or something like that. So it's first of all, it shows it's a very sensitive measure. It's a very high. It's got a very high internal correlation. But secondly, the range is huge. It's just enormous. Comparing with the traditional countries of migration, like USA, Canada, Australia, New Zealand, I compare the EU 15 with those. Well, EU 15 does better on entitlements, legal entitlements. It's largely due to the USA, with what used to be a very bad system. But responsiveness is a very different story, and achieving change. The EU is behind on that. And finally, just for fun, because whenever I investigate something, I look at the correlation with GDP. And sure enough, GDP turns out to explain practically everything. Well, it explains half the variance in the MIPEC scores. I don't know if you can see that. There's nearly half, the R-square is nearly half. And it explains nearly all the other correlations with the MIPEC scores. So in other words, the main issue, the main determinant of how inclusive the system is the wealth of the country. And you see, well, for example, New Zealand way above the norm, Italy, UK, the same, Bosnia doing extremely well. It's not in the Premier League, but still outstanding for such a poor country. And down here, well, oh, by the way, here's Germany, which is quite rich but not very interested in health of migrants. And down here you have a lot of EU 13 countries, Eastern European countries. And you can see that they're totally underperforming. They are poor, okay, but they're not so poor that they couldn't have better facilities for migrant health. So, and the interesting thing is the significant difference between EU 15 and EU 13 is not explained away by the difference in wealth. And you see that reflected in the current policy turmoil in the EU with the Eastern European, well, a number of Eastern European countries being very mean about migration and burden sharing and taking a totally different line from the rest of the EU. Well, not anymore, of course, because we now have the Italian government and the Austrian government joining forces with them. But, so there's a split there which is more than a question of money. So I'll leave it at that. Thank you very much.
I have a question for David about your last page of slide. I noted like the regression line. I was wondering whether you can put like CI, a 95% CI around the regression line, and in that way maybe we can see whether the difference is significant or not.
Yeah, I haven't put the significance levels on that graph, but it is. I think it was beyond 0.05. Yeah. I'll run it again. Thanks for the point.
Thank you. Any more points or questions?
My name is Florence, and I'm Bela's spouse, and I've just been sort of listening to every one of you, to the interesting presentations. I have just a question for the panel. If there's any data collected already by the WHO on migration health, I was thinking that they should have a lot.
If I could just quickly answer one point on that. I advised on a report on women migrants and health, which was published a few months ago, and the WHO said that was the first time that they had addressed specifically the issue of women on the move, women migrants and health. There may be other studies that the team know of, but that's what I was told on that point. So, sorry, I'll let Kol speak and then bounce.
Just very quickly. So, so WHO works essentially through the conduits of the Ministries of Health, and right now they are setting up a global program on migration health. It is, as we speak, being developed, but the WHO Euro out of Copenhagen has a more of an advanced agenda and organized agenda around migrant health, and that's large part of the leadership of the regional director there. And they have a sort of an apparatus, staff members, but it still hasn't germinated as a global program as yet, and that's something that's happening as we speak. There was a resolution in 2017 again related to the compact. Now, this has been one of the I suppose areas where we certainly as a UN family could work better and advocate in terms of global health diplomacy, the need for a stronger program there. But I think it will come. It's just a matter of being sorted out. So in terms of data, there are some. If you go on the WHO website, there is a link on migration and health, but there's no specific data sets yet. And this is part of the problem. If you knock on the door of a Ministry of Health today and say, I'd like to do a project on migration health, who do you speak to? Is it the Director for Tuberculosis? Is it the Director of International Health? And this is part and parcel of the challenge of advancing migration health at a country level. I wish I had time on the case study in Sri Lanka, but you can read about that through the IOM website, the case study on Sri Lanka. Thanks.
Can I? I'd like to add a question to Kol, if I may. Why can't WHO and IOM get their acts together on this and do a combined program?
Well, so for 65 years since the origination of IOM, we've been at the forefront of doing the immigration medical examinations, and that's for member states who request this particular thing. But IOM does provide technical cooperation and guidance for member states who request for specific things. For example, in Cambodia, they said, we need to know if the children left behind have any significant health implication of this dependency of labor migration. And so IOM came in and supported. But although IOM has had a semblance of a global migration health apparatus. We've got regional technical officers in migration health. We've got chief medical officers. I mean, I was a chief medical officer in Sri Lanka, for example. But it's still not tethered to the ministries of health, for example. And so I think it's a work in progress, and it will happen. But we are still in the process of finalizing that.
Thank you. A question or remarks, and thank you very much for very interesting presentations. First, I was very happy to see that this new network is developing, because having worked for humanitarian situations a long time, I remember at the time, and we still have it now, I think this is Emergency Nutritional Network, for example. And there has been that interagency work together, supported with civil society as well, where all the time nutritional studies were done, were collected, interagency guidance was provided, etc., etc. So I hope maybe that is inspiring also a little bit this new network. I was also wondering about the association of WHO with that network. Maybe at some stage it would be good to get them involved, just to have the normative agency there involved and try to influence their work, if you want. Specific question though to you both. When I think about sustainable development goals and targets and indicators, I think one of the most exciting, it's a challenge but also an opportunity, is this idea of disaggregation of existing data by migratory status. And so, for example, there's the health goal, I think it's 5, if I remember well. And so my question to both of you is, isn't what's the potential for disaggregating existing data that is collected from health ministries, from line ministries, etc. There is, of course, always a kind of a pushback between, should we distinguish the migrants among our clients from a, call it a protection perspective. At the same time, we need to collect that data to see whether migrants are doing better than non-migrants or vice versa, right? Especially. So one question is about the disaggregation. I think it has a great potential to make sure that no one is left behind. That is the promise of the 2030 agenda. But then also with regard specifically to Rachel's very interesting method and presentation, what is the comparator group that you're using? So if you want to look at I think the point is to demonstrate that migrants are not vectors of disease. If I interpret it well, so you screen them beforehand, then they come in, and in fact very few cases are developing TB, etc. But how does that compare with the non-migrant group, for example? How do you... So you focus specifically on the well-being of migrants, but I think in particular what we need to see is how migrants are doing in comparison with non-migrants. And when you disaggregate existing health data, either administrative or from surveys, and you compare migrants with non-migrants, then you get a little bit more of that comparative analysis. So just a question about what do you think about this disaggregation? Maybe you find it disappointing that in the SDGs there's not a specific target on the health of migrants, but having the invitation, if you want, to look at all the health-related goals and try to see which one is a priority in terms of disaggregation, doesn't that offer a lot of opportunity as well to pressurize, if you want, the line ministries and the existing data collection mechanisms to add one more indicator, namely migratory status, in order to get that disaggregation and to look over time how migrants are doing versus non-migrants? Thank you.
Take the first question. Thank you so much, Bella. I think if you look at a sort of a health system, if you look at the routine sources of data, so morbidity and mortality, for example, through hospital registries, if you look at the disease surveillance system for epidemiological reporting, and then you look at sort of the surveys, the demographic health surveys in developing regions, or the vertical programs like tuberculosis or malaria, you'd be hard-pressed to find disaggregation with migrant status or for all the variables that were presented in the previous presentation. And that's the challenge. And I think I was going to go through the low-hanging fruit. One of the low-hanging fruits is to really advocate, right, to ministries of health to capture those variables. Now, it's easier said than done. First one needs to enable the rationale of doing this. We did so in a couple of countries, in Thailand, for example, and in Sri Lanka and in the Philippines. There is a concerted effort to include the migrant variable. However, these are exceptions on the bell curve. It's not the norm. So I think you're right. We obviously this needs a concerted advocacy. But the problem is, who is going to do that? And this is where the earlier questions around, if we had a stronger WHO, for example, that's insisting on health systems action plans at a country level, and one of the things was to consider disaggregation at the disease surveillance data, the registration data at hospitals, as well as the DHS surveys. Overnight, you can have a data set where you have cross-tabulation. Easier said than done. However, I think we've had some success in certain countries who have been the labor-sending countries. Actually, they're the ones that we have had more success with. And we have managed to advocate inclusion of those categories into the DHS, for example. But I think this is still not many people are advocates of this. I think this is what I think we need a critical mass from academia, from the UN, from enlightened government policymakers that are demanding this. And in fact, the resolution of the health of migrants is a non-binding thing, and there is no report card, there's no reporting, there's nothing like that. And I think we need a stronger global health governance around migrant health in order to make these type of interventions. Thank you. Rachel?
Yeah, I'll just say quickly, no, it's really important to have that comparison group there. And I'll focus a bit more on the last two projects, because that's kind of what I'm more involved with than the previous work. So with the Million Migrant Project, we're really trying to, so with the main kind of just data linkage project, we'll be able to compare, after linking the data, able to compare the migrants compared to non-migrants by just looking at the hospital records and looking, let's say age, sex, region, and kind of be able to do all those different types of variables. But what I think is really exciting about the app-based project, which is kind of my main focus right now, is we're coming up with the questionnaires, and we're trying to make sure that every questionnaire we ask, or every question that we include, is from a validated questionnaire. So we're using, we're using the England Survey for Health, for example, or other global validated questionnaires to make sure that if we do ask questions about alcohol and drugs, so we're able to look at not only how do migrants in the UK compare to just people within, citizens within the UK, how do these migrants compare to migrants in Spain, for example? If someone else does, let's say, the short form questionnaire 36 and look at quality of life. So we're really trying to make sure that we're very much thinking about how can we use this data, and how will this data be able to be utilized by other people as well.
Thanks to everyone for those responses. I'll just take a question there I'll come to the back with the microphone. Whilst I'm walking, I'd like to say I think the health professionals have a lot of experience and expertise in ethical use of collection and data and analysis of data, and all the questions that we need to consider when we're looking at big data. So there's another conversation to be had there about the appropriate use and of collection of this kind of sensitive data, and how it can be anonymised, and how best used. And I think the health professionals could do a lot of work there with the people working on big data, who very often need to think a bit more carefully about those questions. So now I pass the microphone to Achoma. Thank you.
I did my doctorate on HIV and HIV prevention and treatment among IDPs in northern Uganda. But what I found out is that the impact of social and cultural destruction is often overlooked when in data collection and policy making. So most of the policies don't really meet the needs, or interventions made out of those policies don't really meet the needs of the migrants populations. Something that we need to be thinking about.